Now, it's my great pleasure to introduce you to the President-elect of the British Association of Day Surgery. Anna Lipp is a consultant anaesthetist from Norwich Hospital, and she's going to speak to us about optimisation of pre-assessment services. Thank you, Anna.
Thank you, Ian. Yes, I've been asked to talk about how we might optimise the pre-assessment process, and I thought I would start off by just considering from whose point of view are we trying to optimise the pathway? Is it the patient? Is it the staff? Or is it the hospital? And by the hospital, I mean the sort of administrative processes. So I'll just go through what each of those groups might consider to be optimal for them. Of course, the patient is the most important, so we'll start with the patient. And I think for most patients, they want to visit the hospital as few times as possible. For many of them, that might mean a one-stop service where they can have their pre-assessment immediately after they've seen the surgeon and a decision to operate has been made. But not all patients like this. For some of them, it's been a bit of a shock that they have to have surgery at all, and they'd quite like to go home and think about it before they sort of proceed to commit themselves by having their assessment. So one stop will suit some patients, but not necessarily everybody. For those who don't want a one-stop service and they have to come back for an appointment, I think they want it to be as short as possible, and they want to know that the time they're booked for will be the time it will actually happen. For many patients who are working, they don't want to give up a whole day's work to come and have their assessment, so they might want to have assessment available outside working hours, maybe at the weekends. If they do have to have any tests, which many patients, of course, won't need, they don't want to have to trek all around the hospital having them done, so ideally they want them to be done at the same place as their assessment. If any additional expertise is needed, like seeing an anaesthetist or another doctor, that needs to be available at the same time and place. And any information that they might need to be given also needs to be available to them in a form that they can use. And finally, if the patient's been through all this pre-assessment, they want to be certain that they're not then going to be cancelled on the day. So the assessment must be thorough enough that there's a minimal risk that anything will happen that means they get cancelled later on. So how about the staff? What do the staff want? Well, I think in contrast to the patients, the staff prefer to do their work during office hours. And I know this because we've recently tried to extend our opening hours to include the weekends, and it's not been a universally popular move among the staff. Some people, it works quite well, but not for everybody. The staff prefer to have booked appointments, and in particular, they like the appointment length to reflect what the patient's complexity and likely length of time they're going to spend. We have different lengths of slot depending on how complex we think the patient's going to be. And similarly, you want to match the experience of the staff to the patient's needs. And then again, we want to have any other backup support available quickly. The thing that the nurses really hate is having to hunt around the place to find an anaesthetist or another doctor to give them some advice when they know they need it. So finally, what about the hospital and administrative processes? Well, I think they want it to be cost effective. That probably means using the cheapest staff to do each process. And we now use healthcare assistants to do many of our routine observations and investigations to free up the more expensive nurses for the clinical assessments. They want a steady flow of patients. They hate to see any of their staff sitting around twiddling their thumbs or having a coffee break. And they also don't want anybody to be cancelled or delayed, because an empty operating theatre, of course, is wasting, as Ian has said, a huge amount of money. And they want to make sure that everybody who could be a day case is a day case. So having looked at those different points of view, we can see that they're not all in parallel. There are some differences as to what's considered optimum. And I'll now just go through some of the stages of the process and consider how they might be optimized. I'll look at the timing of pre-assessment and who should be carrying it out, where it should take place, whether you should have one team doing pre-assessments for every patient, and then making a decision as to which route they should go down, and then a bit about documentation. So to start with timing, I think I agree with Doug and Ian that the earliest opportunity for pre-assessment is best. You've got plenty of time to sort out any problems that if they occur, and even rebook the date if necessary. But of course, if it's too far ahead, some new problems may develop. And I think, as we heard yesterday, what you could do if it's a long time ahead is have a telephone checkup just closer to the time of surgery. In some places, investigations may be time limited, and in the UK, we have to swab all our patients for MRSA, and in my hospital, it has to be within a month of the surgery. So that's obviously limits the timing of your pre-assessment, unless the patient comes back for a second time. As we mentioned before, one stop is a good option. The option that is least appealing is assessing the day before surgery, which I'm afraid to say we do still do on some occasions. Who should carry out the assessment? Well, I think it's a bit of a team sport, as in most areas of day surgery, and it should start with the referral from the GP. I'm recommending to our GPs that they should have a fit to refer assessment when they send the patient for a likely surgical procedure. And that would include checking the patient's blood pressure, checking their pulse to see if they're in atrial fibrillation, and checking whether any chronic diseases are well controlled, such as diabetes. I have to say it's not really got off the ground as yet, but it's an aspiration. We know that trained nurses provide a consistent service, superior, in fact, to junior doctors, and this is the model I think most people use for their pre-assessment. If you have a anaesthetist readily available to give advice, you can certainly increase the number of patients who are suitable for day surgery. The nurses will usually default to the safer option if there's any doubt about suitability. And finally, having healthcare assistants, as I say, can support the nurses by doing observations and investigations. Where the assessment should take place, from a convenience point of view for the patients, doing it in outpatients obviously means they don't have to trek around the hospital, but wherever it is, you want to have all your support services readily available for any investigations. For many patients, having their assessment in the same place that their surgery is going to take place has advantages, because they can do a trial run of the parking and how long it takes them to get there, and looking around may make them feel less anxious. Primary care may be an option for some patients. It's certainly more convenient, but it's a lot more difficult to organize. And then finally, in the patient's home, I'm not suggesting we should go and visit the patient at home, although for some very complex patients, we have done a home visit. What I'm recommending is that the patient gets telephoned, or maybe could do their assessment online. And I'll just talk a bit about the issues between face-to-face assessments or telephone. There's no doubt that doing a face-to-face assessment means that you can get everything done in one go, and if the patient needs tests, that's obviously the best option. But for patients who probably won't need any tests, doing it by telephone is certainly a lot more convenient for them. You can telephone them out of hours, and for patients who are working, this is obviously a much better option. And the decision really is based on how likely you think the patient is to need any tests done. Another point of discussion is, should you have one team doing all your pre-assessments, or should you have a day surgery and an inpatient specific team? Now, in the UK, pre-assessment has really grown from day surgery, and the situation in many hospitals is that they have a well-established day surgery assessment team, and then they've now got an inpatient pre-assessment team working in parallel. And I'll just go through the pros and cons of that approach. This is the arrangement that we have in many of our hospitals, where we have two teams of assessment nurses. So the patient attends the surgical outpatients at the top, and the surgeon identifies them as needing an operation, and he now has to decide, is this going to be done as a day case or an inpatient? Now, as Ian mentioned, there are really three parameters to be considered when you're deciding, are they suitable? And I have no doubt that surgeons are very good at deciding whether the operation is suitable to be a day case or an inpatient. I'm less confident that they're very good at deciding whether they're medically suitable, or perhaps even more important, socially suitable. And I think this is where this particular pathway can fall down. So let's just say the patient has been considered by the surgeon to be suitable to be a day case. So they go into the day case team for their assessment, and they then discover that the patient has no social support or for some reason is not suitable at all. So they then have to tell the patient, no, you won't be able to be a day case after all. We're going to have to re-plan your operation as an inpatient. And in my experience, that usually causes delays, I think a bit of unhappiness for the patient who may feel a sort of sense of disappointment that the plans have had to be changed. So what I would suggest maybe is better is if we leave the surgeon just to consider that the patient needs an operation, and then we leave the nurses who are expert at deciding suitability to decide the suitability once they've done the full pre-assessment. So all the patients will go to a pre-assessment team, and then after the pre-assessment, the decision will be made, are they going to be a day case or are they going to be an inpatient? So it saves any changes in plans. The other advantage to this system is that I think you maximize the number of patients who can be a day case. Because if the surgeon decides a patient is going to be an inpatient, say he sees them walk in and thinks they look a bit frail, it's unlikely that the nurses will change that pathway once the surgeon has decided. They will think, possibly correctly, that the surgeon knows best, and if he thinks they need to be an inpatient, that must be true, even if in actual fact they would have been perfectly suitable to be a day case. So you probably end up with more patients being unnecessarily treated as an inpatient if you have two separate teams. The advantages, though, of having a separate day surgery team is that the day surgery team, I think, probably give more in-depth advice to the patient about their management as a day case. And also in many day surgery units, different members of the team take on different roles at different times of the day. So when it's very busy in the morning, the pre-assessment nurses may help with admissions, and then later in the day, they move over and do pre-assessment. Obviously, if you have a centralized pre-assessment team, that becomes much more difficult to organize. So finally, documentation. And this is another subject dear to my heart because we're trying to reorganize our documentation. I think the key things are to make sure that you minimize repetition and that the notes are easy to obtain and easy to find the information in once you've got them. They need to support the nurses in making a decision about patient suitability or what other investigations are needed. And I think for those reasons, an electronic format may have many advantages. In particular, if it links to any investigations they've had done and it provides categorization of the patient once their assessment has been done. Investigations, we heard yesterday that investigations are probably overused, and I think that's true. Francis Chung asked the question, are any investigations useful? And I think it's true that very few of them really make any difference to our management. However, in the UK, as I've said, we have to swab everybody, so that ties us to doing at least one investigation. So how do we know if the process is optimal? Well, we should ask the patients, and surprisingly, patients really like pre-assessment. I think it gives them confidence that they are fit enough for their procedure. Obviously, it's a great opportunity for them to find out what's going to happen and ask any questions. In fact, even if they do have to come back more than once, it's surprising how they don't express their dissatisfaction with that. Another way to look at your effectiveness is to look at how many patients get cancelled, in particular on the day, but even a day or two beforehand. And then unplanned admissions, I think, often reflect a poor pre-assessment process and poor preparation. And then finally, we can look at the day case rate. If the day case rate seems to be low, it may be that a lot of potentially suitable patients are being booked through the inpatient pathway unnecessarily. So to summarize, I think an optimal process minimizes the number of times the patient has to come to hospital. It ensures the patient has all the information they need, and it maximizes their chances of being managed as a day case. And it minimizes the risk that they will be cancelled at short notice. Thank you.
Thank you very much, Anna. I think we'll follow the format and take some questions now, if we may. Any questions from the floor? Anna, can I ask a question? Well, I think we've both experienced the combined pre-op assessments and separate pre-op assessment for day surgery. You mentioned as one of the advantages of having day surgery staff doing the pre-op assessment was that you could multitask them and use them anywhere else. Is there a downside to that as well? Did you find there's a downside to that as well? As in they can be taken away?
Yes, that's true. It's always seen as a sort of a pool of potential workers when it gets busy. And of course, if you've got booked patients, you can't really keep taking your pre-assessment nurses away. So I think that's a downside. I think another downside is if you're expected to cover lots of different areas, you may end up being slightly less skilled in any one of them. And there's no doubt that the nurses who pre-assess both inpatients and day cases, I think, become more experienced and confident, especially at looking at patients with complex medical conditions. It's a knotty problem, as I think Ian and I have both discovered.
Yes. Right, is there any questions from the floor?
Yeah, over there.
Yep. Well, that's better, I can see.
I have seen in some units that they run pre-op assessments in conjunction with outpatient clinics. So any patients who get put in for surgery go in and have their pre-op assessments straight away. Do you think that is a good option?
Yeah, I think it's a very good option to have for some patients. We do it for all the cancer patients who are going to have a very short wait. But as I say, for some patients, the whole visit to hospital is exhausting enough and they don't want to hang around. Inevitably, it's more difficult to see the patient straight away if you have a drop-in service, so they may have to wait longer. I think having a mix of the two works quite well because you can have booked slots first thing in the morning before anyone comes from outpatients. Then you can have the patients coming through from the clinic. So a combination probably works quite well.
Any more questions? I think you've got off lightly. It's good. Thank you very much, Anna.